Love you.
Don't be scared. It's going to be fine.
In the UK, some 3 million major operations are carried out every year.
I'll be there with you all the time, okay? We'll look after you.
But some patients' procedures are so complex, only the best surgeons can perform them.
Everybody happy?
Okie dokie.
As soon as the patient is on the operating table, their life is in your hands.
Adam Brooks and Royal Papworth Hospitals in Cambridge are world-renowned for their pioneering techniques to treat conditions that few others dare to take on.
It's a bonkers job, kind of like something from science fiction.
But pushing the boundaries of modern medicine comes with great risk.
I've got to get this right.
Things can go wrong very, very quickly.
We've got a venous bleed.
You need to be able to accelerate from 10 to 100.
Don't pull, don't pull.
Jesus, what's happening?
The surgeons bear the ultimate responsibility.
We have a problem. There's a big problem. Can you just stop talking?
When things don't go as well as they should, then you start to question, was it something you did?
I have operated with tears rolling down my cheeks.
Doing our job takes its toll, but being a surgeon shows you life is precious.
That's it.
Bravo! Woo! Happy days.
This is somebody's life, and it has to be done perfectly every single time.
Cambridge, home to 2 of the country's most groundbreaking hospitals. Adam Brooks and Royal Papworth.
Morning, Alessandro. How are you?
Based at Adam Brooks, Rod Lang is a world-renowned spinal surgeon.
I became a surgeon because my grandfather was a general practitioner.
Morning, Sam.
He was warm, kind, and very skilled at what he did. So I thought, well, you know, I want to be like him, and he's a doctor, therefore perhaps I should do medicine.
Throughout his career, Rod has advanced and perfected many difficult techniques in spinal surgery.
All surgeons need to be obsessive. Neurosurgeons are perhaps more obsessive than others because there is no such thing as a straightforward spine operation. All these interventions carry significant risk.
We got Pat setting the table up.
I've been in it for 30 years now, and I'm still coming across problems that I haven't seen that precise manifestation of. And many of them are very rare, so it's something that requires total dedication.
Rod specialises in one of the most challenging operations in his field, removing slipped discs from the spine.
And you can see the disc prolapse there.
Slipped or prolapsed discs don't usually need surgery, but in a tiny number of cases, they can impact the spinal cord.
The disc is the fibrous tissue that lies between adjacent vertebrae. Occasionally, some of that disc material can break out and it can find itself pressing on the spinal cord.
His next patient is suffering from one of the worst cases Rod has come across.
As you can see, there is considerable pressure on the spinal cord, which means that the normal messages that are passed from the brain down to the legs to control movement and walking, bladder and the bowel, those messages are not getting through.
The operation is made much more challenging because the disc has slipped in the middle or thoracic part of the spine, which is very difficult to access. It's one of the riskiest spinal operations there is.
You know, I've been doing them now for, 20, 30 years, and, you know, this, I think, is the most difficult operation that I do in neurosurgeries.
And the spinal cord is so unforgiving, isn't it?
He will be assisted in theatre by surgeon Jibin Francis, who came to Adam Brooks 3 years ago to work with Rod.
The spinal cord in the chest region, it does not tolerate any manipulation. An easy way of thinking of it is a bundle of very tightly packed wires transmitting information. It will not tolerate much more than a couple of millimeters of movement. So the margins for error are incredibly tight.
You know, in my mind is always the thought that one one false move would result in paralysis. You know, I often think just the vibration of the drill can be sufficient to tip the balance in an irreversible fashion. So it's not a relaxing procedure, is it?
Rod's patient is 65-year-old psychologist Colin, who lives in Wiltshire with his wife Jan. For the past 9 months, the disc has been pressing down more and more on Colin's spinal cord, slowly paralysing him from the waist down.
I've noticed a few things had changed. I went out for a run. Jan was driving back from doing some shopping and stopped and said, "What's the matter?" And I said, "I can't run anymore." She said, "What do you mean you can't run anymore?" I said, "I just can't." And then I started to look at my legs and noticed that my right thigh was half the size of my left thigh. You're stuck all the time, getting like that. And then standing up is more arms and legs.
We've been together 40 years. The first thing we did was get a dog, and we've had dogs right the way through our married life, and we've walked every day. And then suddenly Colin couldn't walk, and it was devastating, actually.
I used to sort of describe myself as fit for my age or very fit for my age to, I'm sort of disabled now by it. You know, I can't do very much. And I don't do very much. I don't pick my grandchildren up in case I fall over. So.
Well, she's one of the best things.
When Colin was told he'd be wheelchair-bound within months, he scoured the country for a surgeon who could help him.
Some of the first surgeons that I spoke to, the first guy just said, "I can't do this. This is not something that I do, it's too complex." I said, "Well, who can do it, you know?" And when I got to see that guy, he said, "I don't really want to do this type of surgery anymore." In fact, he said, I've ended up paralysing people. So that was pretty. You don't want to hear that, no.
Eventually he found Rod, who was prepared to take on his case and his best chance of avoiding paralysis.
D-Day. I can't wait to get it over with.
No, I bet.
Any nervousness is offset by the fact that I can hardly
Can't walk.
I'm
No.
just thinking, it's getting worse, so.
Yes.
How are you feeling anyway?
Just anxious.
From the start, I've never thought there is a choice of not having the operation because I know that I'm going to be paralysed anyway, so it's a sort of a catch-22. I've got to put my trust in somebody's hands, and as far as I'm aware, he is the #1 surgeon in this type of operation. Rod, hello.
How have you been since I last saw you?
Slightly worse. Yeah,
Okay.
Yeah.
But nothing dramatic?
Nothing dramatic.
So can you just show me what you can do with your legs? If you start with the right one, if you just sort of lift it up.
Yeah, that's...
Can you get it a bit further?
No, that's as far as it'll go.
Right, and if you bend the knee for me.
No, I can't.
Okay.
No, that is as far as...
I think it's a bit worse, isn't it?
Yeah, it is a bit, yeah.
Definitely time to get on with it, isn't it?
Oh, definitely.
Yeah. Well, it'll be a long day, and of course there's a small possibility I could make you significantly worse today.
Yeah, we talked about that, yeah.
So we've got that,
yeah.
You know, you kind of hobbled in.
Yeah.
But you might go out in a wheelchair.
Yeah, yeah.
It is, as we both know, it's a possibility.
Yeah. Yeah.
Okay.
Okay, thanks, Rod.
It's a pleasure. Okay, see you later.
Thank you. Cheers.
By mid-morning, surgery is underway in all 35 theatres at Addenbrooke's. In Theatre 22, Rod is preparing for his operation, which is expected to take over 11 hours.
Right, so is everybody ready?
He has assembled a large team of 15 specialists, including orthopaedic and vascular surgeons.
Right, welcome. Nice to see you.
They will assist Rod to access the slipped disc in Colin's spine, using a technique he's mastered over the years.
Ready, steady, slow, nice and slow. Well done.
In the past, the slipped or prolapsed disc would have been approached through the patient's back.
We're going right side up.
But with the spinal cord directly in the way, incidents of paralysis were unacceptably high.
The first thoracic disc prolapse that I saw operated on was not a happy day. I realised that the surgeon who was conducting the operation didn't really have a plan or an idea about how to do it, and the patient had a very poor outcome. So I decided that I needed to learn to do it properly, and I used to teach an anatomy course at the College of Surgeons. As well as teaching them, once they'd all gone home, I spent the evenings teaching myself how to approach a thoracic disc.
To remove the disc and avoid facing the cord straight on, Rod will access it through Colin's side, but it means having to operate deep inside his chest, performing intricate surgery at his furthest reach. Rod will access the disc from the right of Colin's chest. He will cut through shoulder muscle and remove a section of rib, before drilling through the bone that protects the spinal cord. Once at the disc, Rod needs to remove it without damaging the already vulnerable cord. A 1 centimetre wide bundle of nerves, vital in sending messages from the brain to the rest of the body. Any damage to the cord risks permanently paralysing Colin.
Well, that's just a guess, really.
Throughout the operation, Rod must be able to pinpoint the exact location of the disc.
The spine is a sequence of identical vertebral bodies, and they don't come labelled. Traditionally, this was done with X-rays, counting from the top of the spine, from the bottom of the spine, backwards and forwards, double-checking. There was always a degree of worry that after 6 hours of operating and I finally arrived at my destination, that it might be the wrong destination.
Yeah, that's it. You can close.
To solve the problem, Assistant Surgeon Jibbin has introduced the O-arm scanner, which creates a 3D map of the body.
Yep, that's good. So the first time I tried the O-arm for this operation, I wasn't at all sure that it would work. So now we all need to get out because you're going to do the spin. And what the O-arm does is that it generates a computed 3D image for you by taking multiple X-rays at different angles. I suppose a way of looking at it is a computerized roadmap of that patient's body.
As the operation progresses, Jibbin will use a handheld probe to pinpoint exactly where they are in the body.
I think the bottom needle's on 8, Mr. Lang. 8, 7. That top needle is at 5, 6, so spot on.
With the O-arm scan set up, Rod, Jibbin and the team are ready to start.
Okay, are you happy to start? We'll do everything back to front.
I've got the rib cutter. There are risks with this operation even before you actually reach the spinal cord. We have to cut through the ribs. During that phase of the operation, there's a risk of injuring nerves that run under the rib.
The rib's out and we can see the lung.
And the next structure you encounter is the lung, which again is something you really do not want to damage.
So I'm going to ask you to sort of get the lung down in a second, if that's all right. Yeah, that looks good, doesn't it? We like that. Very good.
It takes 4 hours for Rod and Jibbin to reach Colin's spine.
You get to the actual operation after you've done a few hours of what would be considered operations in themselves. And now you've come to the real operation that you've come to work today for.
So it's unbelievable, it's 2 o'clock and we haven't even done anything.
We haven't even started the operation, have we?
Now begins the painstaking part of the operation.
Right, you got the drill, please?
Drilling through the bone towards the disc.
I know what I'm capable of. I know what the team is capable of. But the thing about surgery, though, is it's always there to bite you. And with any mistake, Colin will become paralysed.
Next door to Adam Brooks is Royal Papworth, the UK's leading heart and lung hospital.
Have you ever seen this?
Cardiac surgeon Narain Morjani takes on some of the most challenging heart operations in the country.
I was always fascinated by the human body. My father was a doctor, and after school, instead of going directly home, used to go to the hospital and wait for him. And it was fascinating seeing what was going on in a hospital and then seeing what he did to make patients better. And I think it's something I felt that I could sort of do for the rest of my life.
Have you ever seen S04E02? No.
Narain's patient today needs a particularly complex procedure to repair 3 out of the 4 valves in the heart.
In terms of cardiac surgery, this is a big operation. It is rare for us to operate on 3 of the 4 valves of the heart, and the combination of that means that they will undergo a long operation, as well as the fact that the heart is quite sick before we start with.
Hello, it's Gertrude.
Yes, that's right, yes.
I'm Victoria. Do you want to come through? Do you want to do this for you?
Thank you very much.
His patient Gertrude has an irregular heartbeat, which has caused the valves in her heart to become defective. Not enough blood is being pumped around her body. Without the operation, her heart will eventually fail.
Perfect. And it's the year of birth?
I don't mind you telling me. 41. I am 80, only just.
Can I just chop this on your wrist?
Is it to make sure I don't run away?
Yeah. More or less.
But I don't feel 80 at all, no. 80 sounds to most people that you're sitting and all you're doing is knitting, watching television. No, it shouldn't be like that. Like to go out, like to go to theatre, to the cinema, go to the beach. Personally, I feel 30.
We'll put you on the monitor, so it'll be little stickers that go here, here, here and here. This feeds straight through to the nurse's desk, so we can constantly keep an eye on your heart rate.
If I talk to a lover, you'll know
Oh, well, no, it'll be up to 180.
At the age of 19, Gertrude came to the UK from Belgium and worked at Gatwick Airport as a stewardess.
I'm happy to be alive. I'm happy to be here in England. I'm happy to have become a grandmother. Obviously, having a problem with my heart suddenly can't do the things that you were enjoying doing. But I hope that I will feel better after the operation. I want to be how people knew me. To say, oh, there she goes again. She just walks all the time, and you know.
So was it a big decision for you to have this operation, or did you notice something?
I only felt ill about 2 years ago. When I went to bed, I'm not exaggerating, my heart kept on pumping. Even the duvet cover was going up and down, up and down, down. And I knew there was something wrong with it, because that was not a normal thing. That was not a normal infection. I could see my life sort of disappearing. I don't know, it's awful to admit. For once I felt that life is too short. No, tomorrow is not a promise.
Yeah, something had to be done.
Something had to be done.
When a normal heart beats, blood is pumped in one direction around its chambers through 4 valves. Gertrude's irregular heartbeat has stretched the tissue around 2 of her valves. They no longer close properly, and blood is leaking the wrong way, putting enormous pressure on the heart. The mitral at the back of the heart and the tricuspid in the middle will need to be repaired using synthetic rings. And the 3rd valve, the aortic, has become so hardened and blocked that it will need to be replaced entirely. Operating on 3 valves, all essential to the heart's function, makes this a complex procedure.
Gertrude will undergo a long operation. And I think when operating on an 80-year-old heart, because the tissues are so fragile, they can easily cause tears or there can be problems. But if Gertrude doesn't have this operation, her quality of life would be significantly impacted. And then eventually her heart would just fail.
Come in, hello.
Nice to see you again. As I said, it is a big operation. Are you happy with us to proceed?
Yes, I'm happy. I'm very happy to go proceed, because without it, probably will deteriorate in any case. So hopefully the time I live, I've got a good quality and enjoy it. How long is the operation going to take?
I would expect maybe 7-8 hours in total. So,
right, so I'll miss my lunch, my evening meal, and all the things in between.
Don't worry about that. We'll save you an NHS sandwich.
Oh, lovely.
We'll make sure you get one afterwards. Cardiac investigations have shown her to have severe mitral regurgitation, severe tricuspid regurgitation, and she's now got severe aortic stenosis.
The risks are great, they're great, but I want to take the chance. I want to take it. I put my heart in their hands because I couldn't see myself sitting and waiting to die.
Just nice and relaxed. Just close your eye. Think about something nice, okay? Cut your round out, so we'll see you. We'll see.
The operation begins by Narain sewing apart Gertrude's breastbone and cutting through the protective membrane, the pericardial sac, to reveal her heart.
The first time I saw a beating heart was truly the most amazing experience. You realise that this organ is the essence of life. Understanding the importance of what you are about to undertake sort of heightens the senses in terms of what you need to do.
Narain won't be able to fix the mitral and aortic valves with blood pumping through Gertrude's heart.
Are you okay to divide your lines?
Yes, please.
So it must be stopped and drained with a heart bypass machine, operated by perfusionist Terry Louise Smith.
The perfusionist has the patient's life in their hands. We're responsible for taking over the function of the heart and lungs of a patient, keeping the patient alive.
Lines are clamped.
To bypass her heart, they place one tube into the right atrium, which diverts the blood away from the heart into the bypass machine.
Give 100, please.
Okay, transfusing.
There, blood is oxygenated before being pumped back through a second tube into the aorta and around her body.
Okay, SEM and tape, please.
With blood no longer flowing through Gertrude's heart, Narain can stop it and fix the valves. But being on bypass can be dangerous.
From going on to bypass, time is critical, and it's a huge insult to the body. It's definitely a high-risk procedure. We have to have sufficient levels of blood to ensure that we can help keep the patient safe whilst we're on bypass. If the average person has 5 litres of blood circulating around inside of them, Gertrude, being small and elderly, she will have less than that, which makes bypass much more difficult.
Whenever you're ready.
Yep. Okay, going on to bypass.
Okay.
You feel a big responsibility that there's a person right in front of you. It's somebody's relative, somebody's much-loved grandma, mother, sister, whoever, that's on the table and that, relies on you to do a good job.
That's full floor there.
Lungs are off.
Procedures running well there.
Perfect, thank you.
Since their first use in the 1950s, heart bypass machines have transformed open heart surgery, allowing surgeons to take on far longer and more complex operations. In the basement of Royal Papworth, a team of 12 clinical engineers are responsible for keeping this vital equipment operational, along with over 600 different types of surgical machines. Martin has been working here for 25 years.
Whenever people talk about hospitals, they always talk about doctors and nurses. Very rarely do you hear anyone talk about the basement dwellers. We're the only hospital in the UK where our clinical engineering department are trained to repair these.
Each of the hospital's 10 bypass machines can take up to 15 hours to service. Today, he's working with colleague Dean to get the next machine back to theatre.
You do the front and I'll do the back?
Yep. Yeah, visually you can see the damage inside there.
There's a damaged one, look. The body's an amazing piece of engineering. Here we have a human-made amazing piece of engineering.
Lift up there. Just try and get it out of that.
This machine is the patient's body for the duration of the surgery.
There's wear there, which looks excessive.
To ensure this finely tuned machine is in perfect working order, every component needs to be inspected and signed off, with some parts of the pump needing to be accurate to within 1/1000th of a millimetre.
We need to drop the needle down about 11 or 12 mil, so we can actually see that that roller is running very true.
The next person on that machine could be a member of your family. It could be one of your best friends, one of your loved ones. This machine needs to work. If it doesn't, it's game over.
As expected, that's well outside of the tolerance, unfortunately. That would have to be replaced.
For Martin, it's much more than just a job.
My dad was a patient here. He had a heart transplant in 1985. He was only the 127th patient to be transplanted here at Patworth. And we got 9 months extra life out of him. It was a blessing.
So that's a really good reading.
We can't afford for these machines to fail. We need to maintain it in tip-top condition. It's got to be A1 every time.
You know, I'm kind of 95% confident that we're at the right level.
Next door in Addenbrooks, surgeons Rod and Gibbon are 4 hours into the operation to remove the slipped disc pressing against Colin's spinal cord.
Okay, so should we get the scope in?
Using a high-powered surgical microscope, Rod has drilled through layers of bone and tissue. A 3-centimetre wide hole now reaches deep into Colin's chest.
The thoracic disc prolapse itself is tiny. So, suction left. And I'm operating deeper in the body than any other operation that I can think of. It's a long way down.
It is, isn't it?
All the instruments are absolutely at the limits of what they can do. I thought with my longer hands that would help. You're using a high-speed drill right at the limit of its reach, and the control becomes less. And slight movement here, big movement down there, which is magnified the longer your drill is. And in theory, all this should be rubbish.
That's all right.
Right, use your wand.
Rod uses the probe connected to the O-arm scan to help find the disc that's hidden deep inside Colin's chest.
So that's on the surface of the vertebral body.
Unfortunately, it's like the dark side of the moon. Everything is made more difficult by the distance that you have to operate through.
At last, they can see the disc.
When I first see the disc prolapse, it's like seeing the top of Everest. You're not there, but actually you've seen it now, and you know that it's within your sights.
Colin's slipped disc is pressing on his spinal cord. To remove it, Rod must work just millimetres away from this highly sensitive bundle of nerves, carefully drilling a trench in the bone around the disc before removing it bit by bit.
Yeah, I'm not going all the way there, but...
Take this corner off, you want to?
The slightest pressure to the cord risks paralysis.
Something bleed, I'm afraid.
Not yet.
No, we've got a bit of bleeding that's troublesome, so...
Blood is suddenly filling the chamber, making it difficult to see the disc below.
Blood has always been described as a surgeon's worst enemy. Blood doesn't transmit light and you can't see through it. So as soon as there is any bleeding, then the operation grinds to a halt. I mean, let's just check everything superficially, don't I mean, we've not done anything to the lungs. It's not as if the drill sort of jumped off into the... The only things that bleed are things that have been cut by the surgeon. And if the bleeding is substantial, the patient's life is put at risk.
Until they can locate the source of the bleed, the operation is at a standstill.
Well, I can see something going. It's definitely coming from outside. The trouble with this operation, Jibbin, is it's all or nothing, really, isn't it? I mean, there's no point just stopping now and... Right over. It is very frustrating. I have to be extremely meticulous to go through every site from which it might possibly be coming. Right, well, that's where it's dripping from. Oh, here we go. What are you talking?
Rod thinks the bleed is coming from muscle above the lungs.
That's just the most dependent point there.
He uses a cauterizer to seal the ends of the vessels and stop the bleed.
Just tracking around, isn't it? Something going over here. Looks better, doesn't it? Yeah. I think that looks okay to me. So that was irritating, wasn't it? You always wonder what sets it off, don't you? You know, it's been sitting there quietly.
Slightest movements, isn't it?
We've got to get the disc mobilised.
5 hours in, and Rod and Jibbin are only now about to start the most critical stage of the operation, drilling a trench around the disc, a millimetre away from the exposed spinal cord.
I think one of the difficult things about this operation is that just as you're getting tired, the stakes are getting higher.
And we only get into the critical bits.
Scary, really. Scary. No other word for it, really. You're scared. The hours don't go by very quickly. How is Colin going to be? Is he going to be back to being able to walk properly? Is he going to be worse? How will our lives together change?
Next door in Royal Papworth, complex heart and lung surgery is underway in all 6 of their state-of-the-art theatres. In Theatre 3, Narain Moorjani has stopped Gertrude's heart. He needs to work quickly.
Up on your green sucker.
Green is up.
Every minute it's stopped, her heart is being deprived of the oxygenated blood it needs to survive.
Vent is running.
If patients are on the heart-lung bypass machine for too long, there can be significant consequences, and some patients do not survive. You want to deliver the most perfect operation, not rushed. You fix what you need to, but with the greatest efficiency.
First, he must correct her irregular heartbeat, which has damaged the valves.
You can see the scar tissue that will stop any conduction.
Electrical signals pass through the heart to make its muscles beat, but in Gertrude's case, these signals are following an abnormal pathway.
This always seems quite difficult.
Narain uses special surgical instruments that make tiny scars in the chambers of her heart
Forceps.
to create new pathways and try and give her a normal heartbeat.
You can clearly see the tissue there.
With the scarring completed, Narain can now start on fixing the mitral valve, responsible for regulating blood passing through 2 chambers in the heart.
We have to peel off this right atrium at the front to get access to the mitral valve at the back.
Operating on the mitral is extremely challenging, as it's tucked away at the very back of the heart.
The mitral valve is one of the most difficult valves to operate on. We have to sort of move some of the chambers out of the way to get access right to the back of the heart. And then we have to have enough clarity to be able to operate on it. I'll take the mitral block.
To access the valve, Narain lifts the heart using 2 surgical retractors.
Are you lifting the heart then, Narain?
No, I'm not. Jay is, though.
Could you stop, please?
As Narain moves the heart, the flow of blood through the tubes into the bypass machine is restricted, making it difficult for perfusionist Terry Louise to keep it flowing back out to Gertrude's body.
Is your drainage okay?
It's not as good as it was.
Okay.
For sure. So there's a very delicate balance whilst we're on bypassing theatre as to what the surgeon needs and what the perfusionist needs. The surgeons have a sort of godlike quality, and you have to be a little bit ballsy, a bit gutsy.
Are you lifting again?
Yes. Is that bad?
My drainage has just dropped off there.
Is that better?
No.
Ultimately, I've got to make sure I get the right access to operate on the different valves that I can. But the perfusionist's job is to make sure the rest of the organs, the brain, the kidneys, that they all function. And flow back up.
Thank you. Coming back up. Yeah, I'm struggling with drainage there, Narain. I'm down at half floor there.
Terry Louise needs 3.6 litres of blood a minute to flow into the bypass machine and back out around Gertrude's body. It's currently flowing at half that.
Is that better, releasing that clamp?
No, I'm down at half floor.
It's easy for things to go badly very quickly. Sometimes I think that you can read the tension in the room.
Can you cope with that, or...?
I'm down at an index of 2.1 at the moment.
If the flow reduces too much, the machine will stop pumping, starving Gertrude's brain and organs of oxygen.
So I'm down on floor there.
Is that any better with that?
Nope.
There's certainly tense moments where we both have to try and adapt our way of working. You have to just remain calm.
Release the top one. Is that any better?
At the moment, yes.
Okay. Okay, so it's the top one. Put that up.
I'm not committing to yes.
Scissors, please.
With Gertrude's circulation stabilised, Narain can now start to repair the mitral valve. The tissue around the mitral valve has become stretched, so it's not closing properly, and blood is flowing in the wrong direction. Narain must strengthen the tissue by first placing stitches around its perimeter, and then parachute in a flexible ring made of a special elastic alloy. This will allow the valve leaflets to close properly again and stop blood flowing the wrong way.
Short needle holders, please.
Every stitch needs to be perfectly placed to avoid damaging the fragile tissue around the valve.
The heart beats 80 times a minute, 60 minutes in an hour, 24 hours a day, and the many days that she's going to live her rest of her life. You need that mitral valve to be able to function many, many thousands of times. Okay, test dose cardioplegia, please. Antegrade, test dose.
With the ring attached, Narain can now test the valve by inflating the heart with blood.
And then you'll see how competent the valve is. So apart from that tiny jet, you can see very good competency of the valve, and apart from that one jet in the middle, very good.
There's a small leak, but it's functioning well enough for Narain to move on with the operation.
As with anything in life, it's about getting the right balance. It is fixing the important bits in the heart, but not necessarily trying to achieve every little bit, because if we are leaving the heart without oxygenated blood for too long, it won't survive. Every minute counts.
Narain now turns his attention to replacing the aortic valve, one of the most important valves in the heart. It controls how blood is pumped to the rest of the body.
Okay, so the best way to get to the aortic valve is from the front and by accessing opening up the aorta. So root vent off, red root vent off.
Red is off, yes.
Due to her age, the leaflets in Gertrude's valve have hardened, stopping sufficient blood pumping around her body.
So here we can see the aortic valve, and then you can see some of the calcification, the thickening at the base of these leaflets. Can I try a 19 sizer, please?
Narain must replace the whole valve. He cuts away the hardened leaflets before stitching in a new synthetic valve measured to fit Gertrude.
The decision making in what size of valve is crucial. And a 21. If you put a valve that is too small, you'll have negated some of the benefits of replacing the narrowed valve. The other side of it is not putting a valve that is too big, because you'll cause 8-year-old fragile tissues to tear. Probably just fits a 21, and you can see that fits in a good supraannular position.
Narain now needs to stitch in the 21mm valve with the utmost care and precision.
If a stitch is placed in the wrong position and damages some of the arteries, the patient may well have a heart attack. So every stitch is crucial that you put in the heart. As surgeons, we all develop this sort of feeling of how to tie knots, how tight to tie the knots, where to put the stitches. A lot of training is done outside the operating room. When I was younger, I used to practice on different materials, different fruits and vegetables, bananas, sometimes an orange, anything to make sure that your technique, when in the operating room, was as good as it could be.
Did you watch the finals of the sewing bee? Did you agree with who won?
I didn't, but Mrs. Morjani did. Some medical person, was it?
Yeah, she's a med student in Edinburgh.
I heard the stories about it. I didn't. Valve, please. So this one's bovine pericardium, which is the lining of the sac around a cow's heart. A lot of people associate tissue valves with a pig. Some surgeons still use those, but I think these last longer because they've got stronger tissue.
Narain has placed 12 pairs of stitches into the tissue where the original valve once sat. He attaches the threads to the artificial valve.
Forehand, please.
Before sliding it down to sit tightly against her heart.
So 2 pairs of forceps, please. Happy? Yeah, looks good.
Having finished the aortic replacement, Narain has one final valve to repair, the tricuspid. But Gertrude's heart has now been without oxygenated blood for 2 hours.
Whilst Gertrude's on bypass, you've constantly got one eye on the clock. Once you get to 3 hours, 3 hours is a long time to be on bypass. After that, you do start to see things change physiologically. As the seconds, minutes, hours tick by, you're certainly conscious that you need to get the operation completed as quickly as you can.
Oh, careful with that. Do you want me to do it?
No, I'm just...
At Adam Brooks, surgeons Rod and Gibbon are nearly ready to remove the slipped disc that's pressing on Colin's spinal cord.
More bone wax.
More bone wax, please. Sorry, I know you're handing over.
After 8 hours in surgery, some of the theatre team are finishing their shifts.
Yeah. Sonia, welcome. Well done, Saras. Which has been excellent, as always.
For Rod and Gibbon, there is no relief.
One of the things about operating on thoracic discs is that the most difficult part of the operation comes right at the end. There is less than a millimetre between the tip of the drill and the spinal cord itself. Am I imagining a bit of movement there?
I know, I've thought there's been movement a few times, but there hasn't been.
Before he can attempt to remove the disc, Rod needs to free it by drilling a trench around it. But he must proceed with extreme caution. One false move could paralyze Colin.
So it is physically incredibly demanding. All the muscles in your hand and your arms are prone to fatigue.
Yeah, it's the sudden advances, isn't it? Yeah.
The drills that we use, if it encounters a slightly harder piece of bone, it has this tendency to jitter, what we call a jitter. It shoots off from the surface of the bone. So for me, that's always been one of the few things that makes me nervous during this operation.
Shall I come around your side for a bit? Let me just, We're getting there. We're getting there. They're not normally this difficult, but it's for all the reasons we kind of expected. It's the level in the the chest, it's high up, it's a big calcified disc. There are lots of reasons why it's difficult.
Just thin it down a bit.
Yeah, it's great.
Yeah, so it's down to about that thick, but it's still just thick enough to cause trouble.
Rod is ready to attempt to remove the disc, but he's now so close to the spinal cord, it's too dangerous to continue drilling. He uses a tool called a dissector to remove small sections of the disc at a time.
Because it's effectively bone, it's still applying pressure to the spinal cord. And I'm thinking, you know, I'm a millimetre here between wrecking him and removing the disc. And after, 8 hours of operating, that's quite a hard place to be.
The final piece of the disc is stuck to the thin membrane that surrounds Colin's spine.
Let's have the dissector again.
Rod needs to cut it out without touching the cord.
Doesn't want to give up quite yet. However much I undermine the disc, it always seems to be stuck.
Longer dissectors.
I have to coax it and gradually free it up. Right, come on, you little fella. Nope, it's not going to work. Have you got a knife that's long enough to get?
Oh yeah, that's right, you do.
Let's have a look. I often feel that I'm fighting with the last piece of disc material, that it's a battle of will between me and it. I've got to defeat it. But of course it holds the upper hand because it knows that a false move on my part could have dire consequences. Oh, so now I get so far. Dissector. But it's not actually about me, it's about Colin, and it's about making sure that he, walks again. Have those scissors again. I can remember the names of all the patients who I feel I've made worse in some way. Come on, Colin. You're out of there.
Oh. Oh. That's actually pretty big, isn't it? It is big.
Oh dear. Sometimes you just got to be patient.
With the last piece of disc removed, Rod can finally take a break.
Good. Well, thank you. That was a bugger, wasn't it?
It was.
When I pull the tiny piece out of the deep dark hole, I feel a mixture of relief, and also there's a slightly comical feeling that I spent all day fiddling around removing this tiny piece of bone. How could it have caused so much trouble and taken so long? And as I walk out of the operating theatre, the energy and focus that has kept me going during the procedure suddenly disappears, and then you begin to realise that actually you're pretty tired, and bed seems a very appealing place to be.
After 11 hours on the table, Colin is taken to intensive care. It will be a couple of days before they know whether the operation has been a success.
Okay, can you fill the heart, please?
In Royal Papworth, Gertrude's heart has been stopped for 2 hours. The longer her heart is deprived of blood, the more likely it will fail to restart at the end of the operation.
Switch off and drain, please.
Narain needs to move on quickly to to the third and final valve, the tricuspid.
With anything we do in cardiac surgery, there is a price to pay. Especially in an operation like Gertrude, where the heart has been starved for oxygen for a prolonged period of time.
This valve is easier to access, so Narain will repair it whilst oxygen-rich blood flows back through Gertrude's heart, protecting the tissue from further deterioration.
Clamp is off and flow back up.
Coming back up on floor.
He's still against the clock, as the sooner Gertrude can come off bypass and the heart can beat for itself, the better.
Operating on a heart that is beating with blood flowing around it makes it more difficult. Placement of stitches is more difficult. It requires even more meticulous attention to detail.
So we've done the parts of the operations, need to close this and then see whether her heart has recovered enough to get her off the heart-lung bypass machine.
With the final valve repaired, now is the most dangerous stage of the operation, taking Gertrude off bypass and restarting her heart.
The longer you're on bypass, the worse the potential outcome can be. Being older, the risks are certainly higher for her.
Okay, you're happy with the air then?
Yeah, happy with the air.
Okay.
We're asking the heart and lungs to take back over their normal physiological responsibilities. We are reducing the amount of work that the bypass machine is doing and asking her heart and lungs to increase the amount of work that they are doing.
Still claps down, John. Should we get the heart to eject a little bit? Would that help? Terry, can you let the heart eject a little bit, please?
Terry Louise needs to maintain a steady flow of blood into Gertrude's heart so it can take over from the heart bypass machine.
We don't want Gertrude's heart and lungs to do too much too soon, potentially overwhelm the heart or the lungs, which could ultimately be catastrophic for her.
Terry, I'm just going to get your SPV vent out.
Okay, thank you.
One blow on the lungs and hold.
Yes. Lungs are coming on.
And then you can go back on full flow.
I'm virtually at full flow there. The heart's ejecting, so I'm not constricting the venous line either. She's doing that herself.
Okay.
Patient would like to come off bypass herself, please.
That's good.
This is what we want to hear.
Yeah.
It's always good to see when the patient's heart is beating well. That's a really good sign that she's a fighter.
Happy to ventilate?
Yes, thank you.
Lungs are coming back on.
Terry, all yours.
Okay, thank you. Coming down and off. That's 2 litres. Down to 1. Venous line's clamped, you're off bypass there.
Okay, thank you.
After nearly 3 hours on bypass, Gertrude's heart has successfully taken back the job of pumping blood around her body.
Pump's empty. Line is clamped.
Pleasure doing business with you today. You happy with your drainage now?
Yes, perfect.
It is an amazing sight, having put a heart through all of that, to see it beating again is just a wonderful feeling. You still know that she's got a long road ahead of her. But there's this great sense of relief that you've achieved, especially in a big operation like Gertrude, that you've achieved all the important things that you wanted to, which will hopefully allow her to live a great life.
Gertrude was allowed home just over a week later. Today, she's back at Royal Papworth for a checkup.
Okay.
Come in. Hello. Hi, Gertrude. Nice to see you. Come on in, please. Take a seat.
Thank you very much.
How are you doing?
Well, I'm fine, yes. I'm amazed myself, actually, that obviously if I walk too fast, I have to go breathe in and breathe out. As my son said, you've got to slow down, mother. Take it easy.
But if you walked at a normal pace, you wouldn't get any symptoms?
No. If I walked at a normal pace, there's no problem at all. I'm very grateful. I hope I'm a credit to you. I'm so pleased. Thank you.
It's a real pleasure, and it's really nice to see you doing so well. Yeah, good luck with everything in the future.
I hope I behave myself as well.
Nice to see you.
Thank you very much.
Okay,
Thank you. Bye-bye. I'm delighted. No, I'm delighted knowing that I am actually doing very well indeed. Age is irrelevant. Yes, I'm 80 years old, but at the same time, I still hope to have a better quality of life, which I'm having now. How lucky I am.
Being a cardiac surgeon is a really important part of who I am, but the responsibility that we carry can be significant. Every decision you make can alter the course of a patient's life. And that is why it is important to have meticulous attention to detail for everything we do.
Five days after his operation, Colin is recovering on the ward.
Hi, Colin. How are you getting on?
Well, thank you. Yeah,
good. How's your walking? Have you got some sticks
no,
or
I
a frame?
started off with one, but don't need it. Yeah.
Show me.
Yeah.
That sounds amazing. Do you need a hand getting up?
No, I'm fine. I'm good.
Just take it easy, because we don't want you falling over at this stage.
Yeah. So a bit of foot drop still.
Yeah.
But, you know.
That's very good.
Yeah.
Yeah, no, I'm thrilled.
So do you think it'll improve more?
Oh, yeah. Do you know what, when we first spoke right at the beginning, I said there was a possibility you could get back to being pretty much normal. So that's what I think. I think you've exceeded all my expectations.
Yeah.
But I kind of knew you were a pretty tough guy when determined.
Yeah, I am determined.
You're more than ready to get home.
Yeah, for sure. Cool. Yeah. Good.
We'll have to do it. Take care.
He's an amazing man. I just feel that the doors have opened on the rest of my life, really, and I can move forward. Yeah. Whereas before, I thought it's going to be a very difficult future. It's a new phase of my life. Thank you.
Colin's recovery has been so swift, he has some good news for his wife, Jan.
Hello.
Hello.
All right.
Yeah, how are you today?
Good.
Ooh, posh new pyjamas.
Yeah. So I'm being discharged today. Yeah.
Today?
Today, yeah. Yeah, I'm coming home now. Well,
It's fantastic.
I know.
You must be Superman.
Did you want me to go and get you a wheelchair, or are you happy to walk?
No, I walked in, I'm going to walk out.
I'm strong. Right.
I'll try not to.
Bye-bye. Thank you so much. Bye-bye.
Bye, thanks.
I'm enjoying my job as much now as when I started. In fact, I could almost say I'm enjoying it more. Come on, Binksy. I don't think I'm ever totally switched off. I think it's there with you all the time. For me, my job is a way of life. It's something that demands dedication.
Next time,
Honestly, I'm petrified.
rebuilding a body.
Are you ready? Nice.
But success is not guaranteed.
We have a situation where things could just fall apart here. I've got to get this right, otherwise she'll lose the lung. Failure is just not an option. Just wait. Can you just stop talking?